May I invite Dr. Chitra Ramamurthy for her keynote address on challenging cases in refractive surgeries. Dr. Chitra needs no introduction, everybody knows her. She is the medical director of Eye Foundation Group of Hospitals and consultant in cornea, refractive, cataract. Over to you, ma'am.
A very good morning to uh, our chairperson for this IC and all the friends in the dais, and thanks KSOS for this wonderful opportunity. So I'll go on to be talking on some of the challenging moments in KLEX surgery after the wonderful talks which we have heard this far. So now this is a very simple, straightforward refractive error 1.5 diopters, normal topography. Normally, when the lenticule is thin in smaller parts, you have the feasibility in smile surgeries to increase the lenticule thickness from 10 to 30 micron, so that makes you feel that the lenticule is thicker when you remove it instead of getting torn. This did not happen in this particular case. The optometrist forgot to increase the lenticule thickness. I wasn't aware of it. All the cuts were done absolutely properly and going quite good. So now that is done. So there's just a little bit of OBL. I create the anterior plane and the posterior plane. And once that is done, all you have to do is to just separate the lenticule from the overlying cap, and then you have to separate it from the underlying cap. Go right end to end. Don't leave any of these ends of the tissue bridges not uncut. And then I remove the lenticule. It comes like a cigarette roll, but I know when I spread it out that just 1/3 of the lenticule has come out. So there is still a lot of it inside, and also I know that the lenticule is too thin. So I have torn it in the process of removal. Then I remove the other part. So I can see the fold of the lenticule in the interface, and then I've spread it out, and I think it's done. Oh, the story is over. The next day, the patient comes with a -2 with 3.5 cylinder, and you can see the topography. So I know I still have a little bit of the lenticule in the interface. So now the next day I have no OBL to guide me. So I just go inside, but what I do is inject 10% tricot. So now this is a big advantage. It doesn't stain the vitreous alone, but it also delineates the lenticule. You can see the lenticule is horizontally placed overlying the pupil. Now it is stuck to the cap. So you need to insinuate your instrument to get one edge. And once that edge you get, you hold on to it, and just like you're doing your X's, you move it circumferentially around and then spread it around. You realize so much of the lenticule is actually left behind. And then if you look at the post-op topography, post-op 6-9, and that's how forgiving the cornea is. And it's a message that you have to remove the lenticule and not leave the patient with an irregular astigmatism. And we even presented a paper about use of tricot in getting the retained lenticule identified. Now this was a patient who got smile done elsewhere 2 months back. He had just a simple 2.753 diopters. He had 6.6 in his left eye. The right eye was 6.36. Even when we did refraction, we got an irregular reflex. And if you look at the topography, it is steep on one side, it's become flat on the other side. If you look at the pachymetry, it's thicker on one side, thinner on the other side. So you know that nasally, it's thicker. So that means the lenticule is there somewhere in the nasal region. And even on a retro illumination in a well dilated pupil, you sort of get an outline of the lenticule which is there nasally. So now here in that time, I did not use tricot, which I would use now. So I decide that I have to work on the undersurface of the cap, which is where this lenticule is stuck. So I have to insinuate my instrument to get a space between the stuck lenticule to the overlying cap. And I have to work on the nasal region, which is where the lenticule is spread out. So with that much information, even if you get the reflection, if you look at the reflection, there is one area inferiorly where we know that the lenticule is actually getting folded. So then you go with your instrument, try to grip that folded area, and then just bring it round circumferentially, and you realize that this much of the lenticule is there. Post-operatively, if you look at the topography, it's all green. The patient has 6.6 and 6 parts. This was a patient who had a -8.5 with 2 cylinder in one eye and a -5 in the other eye. Nowadays, I would clearly not do LASIK even if it was the thickest cornea above -8. but this was done more than a decade back. And this patient had a normal topography prior to the procedure, very thick cornea. But 4 years later, she comes back with an inferior ectasia with my 2 and 4 cylinder. And you know what you have to do now is you have to regularize the topography. So the plan of action is to use one inferior intact segment which would reshape, because that much is enough. So basically you dock the patient and on the femtosecond laser create the channel and place a single segment so that it lifts up that flat steep area inferiorly and regularizes the topography. And the topography did get regular and the refraction came down to minus 2.75 to 0.5 cylinder with the vision improving. The BCVA did improve. So then we waited for a period of 6 months till the refraction topography got stabilized, and then placed the phakic IOL, and the patient had a 6/9 vision. And we actually sent this lenticule to the NN and they found that the LOX levels were lower in this eye. So even if the topography was looking normal, biomechanical instability was what was the cause for the ectasia. Now this is a case, a very routine case. Patient was highly apprehensive. My last of my videos, the things are going good. But you know, I should have known and taken my foot pedal off, because once the incision before that the laser suction stops, the incision occurs in an aberrant area. So I am not able to open up this lenticule. So what I do for the second eye, allow the posterior lenticule cut, the side cut, the cap bud, but I remove my foot pedal before the incision cut is made so that I can redock, because the patient was apprehensive. I redocked and again made a fresh incision. So now in the left eye, all I had to do was, all the cuts were done and I have created an incision. So I go in a routine manner, define the anterior plane, the posterior plane, and I remove the lenticule. But in the left eye, before the incision cut, the laser had stopped. So I could not, that's the last step where you can't do. So what I do is, I use the circle software, make a large hinge and leave that small area, which is for the flap cut, only that much area I leave it open. So now I have actually converted, it's actually a flap, but the hinge is all closed and just one small incision is left. And I go into the interface of this flap and the lenticule is lying there, and then I pull out this lenticule. So this was just that last minute strategy which came to my mind, how to deal with this moment, and the patient actually did well in both eyes. So last but not the least, I'm sure I've spoken to most of you all at different moments in my career. I'm contesting for the post of Vice President AIOS and would be really obliged if you keep me in mind. Thank you very much. Any questions?
Thank you.